Session on GI updates. For the sake of time, we will be moving on to the final session of the day. This session is comprised of 2 online presentations and 1 live presentation. Allow me to introduce our distinguished chairs for part 1 of neurology. Please welcome Dr. Ayman Ben Ayad, Neonatal Perinatal Medicine, Pediatrics General, Tawam Hospital Al Ain, and Dr. Zara Ashraf Siuji, Specialist Pediatrics and Neonatology, Abu Dhabi. Dear doctors, the session is yours.
Assalamu alaikum, everyone. I'm Dr. Zahra. I'm an Arab Board certified pediatrician and neonatologist. And I would like to thank Dr. Ayman and Dr. Junaid for this opportunity and this great series of conferences that they're conducting now for the 12th year. It's great to still see a number of the delegates here staying with us towards the end of our conference. Dr. Ayman and myself will be chairing this last session, which is part 1 of neurology. It gives me great pleasure to introduce our first speaker. She is talking to us all the way from Philadelphia, USA, Dr. Siobhan Macy. So Dr. Macy is a renowned pediatric neurologist at the Children's Hospital of Philadelphia. She is double board certified in pediatric neurology and epilepsy with the American board, and she is going to discuss genetic testing in neonatal seizures. Let us welcome Dr. Macy, and that's a very good morning to her as well.
All right, good morning from Philadelphia. I'd first like to thank the organizers for the opportunity and invitation to speak with you all today. And for my first presentation, I will discuss genetic testing for neonatal seizures. I do not have any disclosures. So our objectives for the next 20 minutes or so are to identify the most common genetic diagnoses of neonatal epilepsy, to describe the signs and symptoms on the history, examine ancillary testing that should increase one's suspicion for a neonatal genetic epilepsy, to discuss the approach to testing for these epilepsies, and then to lastly identify the impact of obtaining a genetic diagnosis on treatment. So from numerous epidemiological studies, we now know that the highest incidence of seizure across the human lifespan is actually in childhood. And within childhood, actually the highest point where children experience seizures is in that neonatal period. And there are a variety of potential causes for neonatal seizures, and I'll get into that in more detail in my next talk. But this is a lovely schematic from the International League Against Epilepsy's recently published classification schematic for neonatal seizures. And here they highlight some of the more common etiologies for seizures, with each bubble sort of the size of each bubble indicating the frequency with which we see those etiologies. And obviously the acute causes of seizures such as HIE, vascular abnormalities, intracranial infections are the most common diagnoses that we see. But we see from the schematic that genetic diagnoses, metabolic and brain malformations are not uncommon, and so definitely worth considering when we meet a neonate with seizures. Now, there are numerous potential genetic causes of neonatal epilepsy, and you can see several subcategories within those, that the broader category of genetic epilepsy is listed here. So those subcategories include malformations of cortical development, vascular disorders, which can result in epilepsy, metabolic disturbances, various syndromes in which epilepsy is part of a larger systemic disorder that the neonate is facing, and then genetic or cellular changes. And this last box of genetic cellular changes is actually the highest percentage of causes that we see within the realm of genetic neonatal epilepsies. And the genetic cellular category includes channelopathies, disorders that impact, or genetic causes that impact the synaptic vesicle docking, and then disorders that impact cell signaling. And we'll get into that in a bit more detail. Now, again, within the cellular genetic diagnoses, overwhelmingly channelopathies are the most common cause of neonatal genetic epilepsies. And so if you take nothing else away from the talk today, I want you to remember that for a neonate with suspected genetic epilepsy, channelopathies are the primary cause, and the two primary genes that we see in overwhelming numbers are KCNQ2 and SCN2A. Now, there are other genes within the channelopathy category, such as KCNT1, KCNQ3, that we do also certainly see. But far and away, if you meet a neonate with a genetic epilepsy and you're asked to guess the gene, if you say KCNQ2 or SCN2A, there's a greater than 90% chance that you're going to be right. Now, this is a lovely schematic from a review paper from Dr. Senna Wong from Lurie Children's at the University of Chicago that highlighted a lot of different portions of genetic epilepsies in neonates. But one thing that I love from the schematic is that it highlights that for those two disorders that we see most commonly, KCNQ2 and SCN2A, that there really is a spectrum of disease presentations for both of them. So on the milder end of the spectrum, we can meet neonates who will have a self-limited course of epilepsy where their seizures will naturally abate in infancy or toddler years, and those children will have good, normal neurologic developmental outcomes. Different point mutations within the exact same gene, though, can result in a much more severe presentation. Neonates with these changes can have epileptic encephalopathies in which they have ongoing seizures that are intractable and refractory to common treatment practices. They can have developmental disorders, developmental delay, neurobehavioral disorders, and movement disorders as well. So these are common, but they are a spectrum and what you can see a patient presents with. I have listed here also the other genetic cellular changes that we can see, although again, less commonly than the channelopathies. So the most common genetic diagnosis that we see that interrupts synaptic vesicle docking is STXBP1, which again is a spectrum disorder. And in the category of cell signaling dysfunction within the nervous system, we have CDKL5, which tends to be less of a spectrum, and neonates tend to present with a more severe course. This is data from the Neonatal Seizure Registry, which is a multi-center research collaboration of actually now 10 tertiary care centers in the United States, of which we at Children's Hospital of Philadelphia are one. And this is a collaboration of hospitals which proactively monitor high-risk neonates with continuous EEG monitoring as recommended by the American Clinical Neurophysiology Society. And this is data from our initial work that was published many years ago now, but is the largest contemporary cohort of neonates with seizures, just kind of looking at the different clinical characteristics that we saw in our cohort overall. Here, I just wanted to highlight the etiology. So we see that both in term and preterm neonates, the acute etiologies, HIE, stroke, hemorrhage, infection are the most common, but a not insignificant number of our cohort did have seizure, neonatal epilepsy as their presentation, about 13% of our cohort. And we met patients in both term neonates and preterm neonates that did present with epilepsy. And when we look at the subtypes of epilepsy that we saw in our cohort, of the 79 neonates that we met, 44% of them had an epileptic encephalopathy. So this is a scenario, a clinical scenario, in which the patient has an extremely abnormal EEG background, also has numerous seizures, and the impact of that abnormal background and the numerous seizures is felt to add to the patient's encephalopathic presentation. Roughly 40% of our patients had brain malformations, 14% had benign neonatal, familial neonatal epilepsy, and a minority, just 1%, presented with benign neonatal seizures. Interestingly, the rates of genetic testing did vary by the clinical presentation there. So we had high rates of genetic testing done in our neonates that presented with epileptic encephalopathy and brain malformations. About 80% of both of those categories ended up having genetic testing sent. But the yield of that genetic testing did vary greatly by presentation. So for our patients with epileptic encephalopathy, we actually found a genetic cause in about 83% of them, whereas for our patients with brain malformations, though we sent genetic testing at a similar rate, our yield of genetic testing was much lower, with just finding an answer or a genetic answer in about a quarter of the patients. Diving a bit more into the specifics of each of those categories within our neonatal seizure registry. So looking at the neonatal epileptic encephalopathies, which again was our largest portion of the cohort, the most common diagnoses that we found were not surprisingly the channelopathies, specifically KCNQ2 and SCN2A, but the other genetic diagnoses that we did see are also listed there. Key features that we found with our epileptic encephalopathy patients: they essentially all had a very abnormal EEG background, most typically burst suppression, which I'll show an example of in a bit, but is a severely abnormal background that portends a poor outcome as well. These patients had a high seizure burden, so they had seizures that fell into the many or frequent recurring seizure categories, seizure burden categories. And seizure onset tended to be slightly later, happening after day of life 2 to 3 for these patients. For our patients that had benign familial neonatal epilepsy, again, this was a smaller percentage of our cohort, but the most common etiologies were, again, channelopathies. And again, just to remind us that these are spectrum diagnoses. Though the presentation of these patients was more benign, KCNQ2 was still among the most common genes that we found in our group, along with KCNQ3 and a few others. In contrast to our patients with epileptic encephalopathies, the EEG backgrounds of these patients were either normal or very mildly abnormal, and these patients had very rare seizure occurrence. And similar to our epileptic encephalopathy patients, these patients with benign familial epilepsy did also have later onset of seizures, with seizures occurring several days after birth. Looking at our last category within the neonatal epilepsies in our neonatal seizure registry, we have the cortical malformations of development, which are neuronal migration disorders, which result in abnormal structural changes in the brain that can put the children at risk for epilepsy, among other issues. So just kind of going across the screen here with examples of some of the diagnoses that we saw. So we have polymicrogyria, which I'm not sure if you all can see my pointer, but affecting this child's right side of their brain. Polymicrogyria involves having numerous shortened, malformed cortical sulcations that kind of have this cobblestone appearance. Next, we have megaencephalopathy, which is the enlarged hemisphere here affecting this child's left hemisphere, where not only is the tissue enlarged, but all of the tissue cells within that hemisphere are also abnormal and have abnormal signaling between them. Next, we have lissencephaly, which involves a lack of sulcation, so giving a smoother appearance to the cortex. And then finally, we have schizencephaly, in which there's a cleft or a schism within the cerebral hemispheres. And actually, for this patient, both hemispheres are affected. On the right side, we have a very large schizencephaly, but on the left, there's also a smaller cleft there within the cerebral hemisphere. And when we looked at this proportion of patients within our cohort, interestingly, about a third of the patients actually came to presentation for seizures that were felt to be due to comorbid acute illnesses. So these were patients who ultimately were found to have cortical malformations, but may have presented with a history that was more consistent with HIE or an infection, and on further workup were found to also have a cortical malformation. Common genes that we found listed there that affect cortical integrity were TUBA1A, DCX, LAM1, SETBP1. And these patients had very abnormal EEG backgrounds as well. Similar to our epileptic encephalopathy patients, we often saw a lot of epileptiform activity as well as burst suppression. A high percentage of these patients had subclinical seizures, actually, and when they did have seizures, they had frequent seizures, also often meeting criteria for status epilepticus. And similar to our other groups with genetic epilepsies, seizure onset was later, starting after the second day of life. We then looked at the differences between our patients within the neonatal seizure registry who had epilepsy versus those who experienced the more common acute symptomatic seizures. And we found some interesting differences. So first, in terms of EEG monitoring, those with genetic epilepsies were more often to require EEG monitoring for suspicious clinical events for seizures, as opposed to our patients with acute symptomatic seizures who often were monitored because of an encephalopathy appearance or because they were a high-risk group who automatically warranted EEG monitoring. As I mentioned with our patients that on the previous slides, the presentation of both clinical and electrographic seizures in our patients with genetic epilepsies was later. So on average occurring, on days beyond days 2 of life, 3, 4 of life in those patients with genetic epilepsy, as opposed to those who have acute symptomatic seizures who tend to present with clinical seizures and electrographic seizures within the first couple of days of life. While subclinical seizures were present in both groups, the patients with genetic epilepsy were less likely to have subclinical seizures, and again, often brought to attention because of clinical seizures. And then, I guess not surprisingly, the patients with genetic epilepsy were more likely to be discharged on an anti-seizure medication. Again, given that they're receiving a diagnosis of epilepsy, one would assume that they have an ongoing risk of seizures beyond the neonatal period. So I want to change gears a little bit and talk about seizure semiology briefly, because this, I think, can be helpful in informing if and when one should consider a genetic epilepsy for a neonate with seizures. As I mentioned earlier, the International League Against Epilepsy has recently published a classification paper for neonatal seizures and how we should think about them and classify them. And as a part of that, they have sort of rearranged the description of neonatal seizure semiology, or the appearance of what the seizure looks like when a neonate is having a seizure if they have outward clinical signs. And the major categories that those semiologies can fall into are motor movements, non-motor seizures, sequential seizures, and unclassified. Now, within motor, I think most of those definitions have remained pretty stable. So automatisms, clonic activity, spasms, myoclonic activity, tonic activity. Similar with non-motor. Sequential is a newer term that they came up with in this publication, and essentially describes a neonate who has multiple semiologies within their seizure. So a neonate who maybe starts with rhythmic clonic jerking activity and then moves to a tonic phase where they have stiffening of the extremity, and then maybe has an autonomic phase in which there is a change in vital signs or a change in respirations. That would be a sequential seizure because it encapsulates multiple of the other seizure semiologies within it. And it's important to consider seizure semiology because that can help with informing etiology. So this was a nice study that looked at 20 neonates with epilepsy, and you can see the genetic diagnoses that they found listed there. Again, not just to keep, bringing this point home, KCNQ2 and SCN2A always listed among the other genes there. And they compared the clinical characteristics of those patients with epilepsy to 40 other neonates that had acute symptomatic seizures. And what you can see here is patients that had acute symptomatic seizures, so specifically HIE and stroke they highlighted here, tended to have clonic seizures, so rhythmic jerking, or they had electrographic only seizures, meaning that they did not have any outward clinical signs for their seizures, and without EEG monitoring, those seizures would not have been diagnosed. On the other hand, patients that had channelopathies, again, where we're seeing KCNQ2, SCN2A, KCNQ3, those patients uniformly in this cohort presented with tonic seizures. And patients who had cell signaling processes such as BRAT1, they presented with myoclonic seizures. So one of the key takeaways from this point was that tonic seizures and myoclonic seizures, when they're present in a neonate, should clue a provider into thinking about a neonatal genetic epilepsy as opposed to acute symptomatic seizures. And there's been a recent systematic review that sort of complemented the previous single center data. So this review looked at ultimately a total of about 150 neonates, about half of whom had a genetic epilepsy actually. And they looked at various features of these neonates, including seizure semiology and EEG background. And this is a big chart that has a lot of numbers, so I just tried to summarize it quickly on the side. But they found that essentially the neonates that had acute etiologies for their seizures tended to have clonic seizures as their presentation, again, that rhythmic jerking, or autonomic features of their seizures, vital sign changes, respiratory changes, heart rate changes as their presentation. That's in contrast to the patients that had genetic epilepsy, and they did break them down as to if they had brain malformations versus channelopathies versus another type of genetic epilepsy. But key seizure types that they found there were tonic seizures, again, and epileptic spasms. Noticeably, we're not saying clonic, and notably for the acute etiologies, we did not say tonic or spasms. And in that paper, they also assessed EEG background and differences between the various etiologies regarding EEG background. And for acute etiologies, they found that patients tended to have focal changes. So whether that be epileptiform activity like sharp waves or spike waves, slowing or attenuation, that activity tended to be focal or multifocal, affecting multiple parts of the brain in our acute symptomatic etiology patients. For our patients with genetic epilepsies, again, similar to what we saw with our neonatal seizure registry data, those patients tended to have burst suppression as their predominant background pattern. So very, very different backgrounds. And just because I've mentioned it several times now, I wanted to give you guys a snippet of what burst suppression looks like on EEG. So we have these bursts of very high amplitude activity that does not have any of the typical features that we would expect to see in a neonatal EEG. And those bursts are separated by interburst intervals here, in which we have attenuated, suppressed EEG activity. This pattern is invariant and is not reactive to external stimuli, which is part of what adds the abnormal features. And sometimes we are using pharmacological treatments in older patients to achieve a background like this for recurrent seizures. But when a child's brain makes this pattern on its own, for us, it's a very bad prognostic sign. And again, this is the pattern that we saw with many of the genetic epilepsies. So when should one consider a genetic etiology for a neonate with seizures that they are needing? So I just put a couple of sort of red flag things that I think stand out to me for a neonatal history or studies that raise the likelihood that a genetic etiology could be at play. So I think first starts with the history. So if we know that acute etiologies are by far the most common reason why neonates experience seizures. But if there's no history to support an acute injury, there's no evidence of a perinatal asphyxia or a hypoxic ischemic event to kind of explain why a patient may be encephalopathic, that is going to be your first red flag. Taking a thorough history is important, a family history. So if there's a family history of neonatal seizures, as many of these genes are inherited in an autosomal dominant fashion, particularly for the benign familial forms of them, that will certainly clue you in as well. If on exam, again, a patient is encephalopathic, but without a history to sort of explain why they are encephalopathic and medications, without a medication history to explain why they're encephalopathic, those would raise red flags. A patient that has dysmorphisms, and we're thinking that this could be part of a larger syndrome. Looking specifically at the patient's seizures, the semiology, as we mentioned, is going to be important. So if we need a neonate with tonic seizures, myoclonic seizures, or epileptic spasms, those are huge red flags. We don't typically see those seizure types in most of our patients with neonatal seizures that happen due to an acute cause. Tonic seizures, particularly, most often are going to be seen with those channelopathies, which again are KCNQ2 and SCN2A overwhelmingly. The timing of the seizure is important. Acute symptomatic seizures typically present in the first 1 to 2 days of life. We meet our patients that have genetic epilepsies most often beyond that time period, so after day 2, 3, 4 of life. The EEG background, as we've mentioned before, very important. If it's extremely abnormal, having our most severely abnormal pattern of burst suppression, that's going to be important and clue us in, stand as a red flag for genetic epilepsy. And then lastly, I just threw in if we're treating with traditional anti-seizure medications and not really having any response, that would be another red flag that maybe there's something else at play as well. And when we meet a neonate for whom we are worried about a genetic epilepsy or if those red flags are present, how do we approach that workup? So I think this is a nice sort of schematic of how we think through things at CHOP as well. Obviously, as with everything starts with the history and physical examination, which are going to clue you in, ruling in or out some of those red flags that we previously mentioned. Obviously, if the child is brought to attention, likely because of seizures, so having them on EEG and having a good at least 24-hour screen to see what the EEG patterns look like and if they are invariant or reactive is going to be important. In a child who we don't have a clear etiology for, we would quickly move to neuroimaging, ideally with magnetic resonance imaging as our gold standard of neuroimaging. And depending on what the MRI did show, we're probably also doing concurrent metabolic testing with newborn screening that's routinely done. But in addition to that, serum, urine, and cerebrospinal fluid studies that can help rule out some of the more, less common metabolic diagnoses, but important to rule out because they do have treatment implications. And then lastly, depending on what was found on MRI or if nothing was found on MRI and the metabolic testing results, we pretty quickly these days move on to genetic testing if our suspicion is high for a genetic epilepsy. And there's two predominant forms that we use for genetic testing. So the first, we tend to start with the targeted epilepsy gene panel. And depending on the company that's used, these panels can range from anywhere from 50 to 350 of the most common genes that we know can cause epilepsy and seizures in children. And some of the panels are actually more specific just to neonatal genes as well. Though the childhood panels do include all of the relevant neonatal genes that we would be worried about. We tend to start with panels because they just have a faster turnaround time. And again, some of these are treatment does depend on having a diagnosis. If depending on comorbidities, physical exam features that may be present, we may also send a microarray to assess chromosomal integrity with that first pass of genetic testing. If we don't have an answer from an epilepsy panel and or depending on the patient's initial presentation and comorbidities, we move pretty quickly onto whole exome sequencing, which is a broader look at the genetic sequencing, or at least the portions of it which we are able to confidently interpret today in 2023. Rather than focusing on 50 to 300 genes, we're now able to examine thousands of genes, which obviously takes more time. And so the turnaround time does take a bit longer than the epilepsy panels. That is with the caveat that for most labs, you can request rapid sequencing if you really do have a high suspicion and feel like it's going to impact a patient's treatment plan and care. And some of those turnaround times can be as short as 1 to 2 weeks. And it's important to make these diagnoses because, as I alluded to in the previous slide, it can impact treatment decisions. So we now know that for the channelopathies in particular, KCNQ2 and SCN2A, those diagnoses when presenting in the neonatal period respond very well to sodium channel blockers. And there have been numerous studies that have sort of reiterated this. Phosphenotoin and phenytoin, carbamazepine, oxcarbazepine, those sodium channel blockers work really well in a neonate with a channelopathy, specifically KCNQ2 or SCN2A. So if we're highly suspicious for that, and seizures aren't stopping from our traditional treatments, that is typically where we will move to next with treatment. We also know for some of the other epileptic encephalopathy genes like CBKL5, KCNT1, where maybe those treatment courses tend to be a little bit more difficult and seizures are a bit more treatment resistant, that moving to non-pharmacologic treatments with things such as the ketogenic diet sooner rather than later can be particularly meaningful to those patients. And then just on the other table here, just to highlight this, though we're not, this is not to talk about metabolism, but with genetically diagnosed disorders of metabolism, there are significant treatment implications because until one repletes the enzyme or the vitamin that's depleted, seizures will continue and will persist despite traditional anti-seizure medication. So again, having that diagnosis, though it's rare, is really important because that's going to really impact the child's treatment course. And in line with this, the International League Against Epilepsy, I've mentioned before that they published recently a classification scheme, but they are in the process of publishing a treatment guideline as well, which is available for consumption on their website. That was not published yet. And I will go through many more of these recommendations in my second talk as they apply more globally to neonates with seizures. But I wanted to highlight this one recommendation or two recommendations here about anti-seizure medication. So they note that for second-line treatment, so patients who haven't responded to the first anti-seizure medication that has been given, that there are a host of other second-line treatments that one can consider. However, the second bullet point here is that if a channelopathy is known or suspected as the etiology of the child's seizures, then a sodium channel blocker should be used as the second-line anti-seizure medication. So that is highlighted in part of the only neonatal seizure treatment guideline that will be published to date. They also highlight in that guideline that for neonates where there's a suspicion of a vitamin-dependent epilepsy, that trials with vitamins, pyridoxine, pyridoxal phosphate should also be utilized and are safe to do in a neonate where maybe we're awaiting genetic confirmation, don't have an answer, but they aren't responsive to our traditional seizure medications. Trying to treat them for vitamin deficiencies can be helpful as well. All right, so with that, I will conclude. Final points here are just that about 10 to 15% of neonates with seizures actually have an underlying epilepsy condition. The most common genes that we encounter in neonatal epilepsy are KCNQ2 and SCN2A, both of which can have a spectrum of disease presentations ranging from mild to very severe. Genetic epilepsies should be considered when you meet a patient who has seizures later in their course. They have seizure semiologies that are tonic, myoclonic, epileptic spasms, or sequential seizures, and or they have burst suppression as their background on EEG. Targeted epilepsy panels and whole exome sequencing are genetic testing modalities of choice, and sodium channel blocker medications such as carbamazepine, oxcarbazepine, and phenytoin and its derivatives are reasonable treatment options to consider if we have a high suspicion for genetic epilepsy. And with that, I will conclude.
Thank you. Thank you very much, Dr. Macy, for this impressive talk. We will keep the questions towards the end of the session. We'll move on to our next speaker, Dr. Nicholas Hook. Dr. Nicholas is a respected consultant at Kennedy Hospital in Al Ain. He has had extensive training and experience in reputable centers in the United Kingdom, and he holds a PhD in pediatric neurology. He's also the author for the Oxford Handbook of Neonatology. Today, Dr. Nicholas will talk to us about point-of-care testing to evaluate the neonatal brain. Please let's welcome Dr. Nicholas.
Okay, thank you for the kind introduction. Thank you to the organisers for the invitation to speak. It's a pleasure to be here with you, and thank you all for staying to the end. Okay, I have no financial disclosures to make. So great double acts. Some of the older members might recognise Laurel and Hardy, Batman and Robin. And for the neonatal neurologist, thank you. For the neonatal neurologist, AEG and brain ultrasound. One gives a window into brain function, the other a window into brain structure. And in the next 25 minutes, we will look at each of those, look at the benefits, the uses, and also the limitations. They're both point-of-care tests. Point of care means at the place and the time of care. It's really en vogue in neonatology right now, and rightly so, because we look after a population of babies who are very vulnerable, particularly to brain injury, and they require close monitoring. So on this side, on the left-hand side, there's a schematic here about conventional testing. So let's say with full EEG or brain MRI. You can see there are a number of different steps and processes which involve different systems, and a result can take days to get to the clinician. Most importantly, it's outside of the hands and control of the treating physician. When you compare that to point-of-care testing with ultrasound or AEG, we can arrive at a diagnosis and intervene much more quickly. So this has benefits for the patient, not having to travel to a scanner, avoiding sedation. It benefits the clinician because we can provide more effective care. It's cheaper because actually an ultrasound is a fraction of the cost of an MRI. And obviously there's huge public health benefits as we can reduce disability in children in society. So let's look at EEG, conventional EEG to begin with. So neurons and glia in the brain produce electrical charges which we can record at the scalp using electrodes. And it's analogous to monitoring brain activity. And certainly it's the gold standard when it comes to things like diagnosing neonatal seizures. There's a big but with that. Worldwide, I wonder how many babies have access to expensive EEG equipment, a technician who can apply electrodes and mount a recording, and a neurophysiologist who's trained in neonatal EEG to interpret the trace. And how often does that happen at, let's say, 3 a.m. on a Saturday morning? So that's where AEG really comes to the fore. So AEG is like a simplified version of EEG. We take 1 or 2 channels of conventional EEG. The trace is filtered out to drown out low and high amplitude noise. It's rectified. It's plotted on a partially linear, partially logarithmic scale. And then it's time compressed so that we can view hours of activity in the brain in one screen, completely different from EEG. The circles here represent where we would put electrodes on a conventional neonatal EEG. The red circles here are where we put the AEG electrodes in the P3, P4 positions for a single channel. We can add the blue circles, the C3, C4 positions, to give two channels, and importantly, we can lateralize the traces so that we have information about the right brain and the left brain. So when can we use AEG monitoring? Well, I would suggest these are probably the 2 most important, most useful considerations or clinical scenarios. One is the baby who's born in poor condition at birth, where we can reliably diagnose hypoxic ischemic encephalopathy. We can gain valuable prognostic information following hypoxic ischemic encephalopathy, and we can also decide which patients might benefit from therapeutic hypothermia. The other scenario is abnormal movements, where we can diagnose seizures and we can help to guide our anticonvulsant treatment. So this slide shows traces that we find in term babies with hypoxic ischemic encephalopathy. On the right side, you can see the pattern classification, which is probably the most commonly used. It was first proposed by Linda de Vries. And there's many others, but essentially it divides traces into normal and abnormal, and it's very reliable to diagnose hypoxic ischemic encephalopathy. So this slide I actually created a long time ago. It was published, and I can always tell which one's mine because I photoshopped some of the traces and I spliced them together. So if you look very carefully, you can see bits of it are identical. So we can diagnose HIE at the cot side. But why is that important? It's important because time is brain. So this y-axis shows brain energy in a baby who suffered hypoxic ischemic encephalopathy. And you can see during the insult, let's say placental abruption, brain energy plummets. And neurons and glia die. There's absolutely nothing we can do about that. And then if we effectively resuscitate, there's this partial recovery of brain energy. But actually, an excitotoxic cascade has already been triggered, which is going to cause a slower decline, a secondary energy failure, which is going to lead to delayed cell death. Now, this phase of delayed cell death actually accounts for a great deal of the total brain injury, which will lead to disability and death. And we have a time-critical therapeutic window in which to institute hypothermia, which is the only effective treatment for this condition. So we need to be able to reliably diagnose this condition in order to decide which patients would benefit from cooling, because this has lifelong implications. And also to help us decide which babies won't benefit from cooling, because actually that has adverse effects like increased sedation, length of stay. So AEG is very good at predicting long-term outcome. This is just a way of graphically illustrating a few studies, but this is data from Marianne Torreson's paper when I was a PhD student there in Bristol. And each dot represents a baby with HIE who was cooled. And along the x-axis is how long the AEG trace took to become normal. So if you look at the blue dots, when the trace was normal by 24 hours of age, all these babies were completely normal at 2 years of age. On the flip side, if you look at the traces of which never became normal, even by 96 hours of age, all those babies either died, the black dots, or were disabled by 2 years of life. So AEG is a fantastic predictor of long-term outcome. So the other thing I was going to talk about is seizures. So what is the trouble with seizures that makes AEG so useful? So if you look at the top panel, this is sort of composite data from several different studies. So if you look at the top panel, abnormal movements, when NICU physicians, we're talking about physicians, not nurses or anybody else, when physicians documented seizures in the charts, that's how many times they got it right, if you like. Okay, so about 20, in this particular study, 26% of the time, the abnormal movements that they thought were seizures were seizures. The rest of the time, they were not seizures. So we're not very good at differentiating abnormal movements from seizures. The middle panel, so these are babies with documented seizures on EEG, so real seizures. So you can see that the majority of the time, babies have at least one subclinical seizure. That means they have a seizure with no outward manifestation, no movements. And about a fifth of babies will only ever have subclinical seizures. They will never shake or convulse. And then the bottom panel, when you look at all the seizures recorded on EEG, you can see that the vast majority of seizure epochs will never have a clinical manifestation. So I think what we can conclude from this is we're not very good at diagnosing seizures as clinicians, and looking at the baby is not a good way to diagnose seizures. So that's where AEG can help us. So these, I won't go into interpretation because there's a session tomorrow on interpretation. But these traces show characteristic patterns that we see in neonatal seizures. These are highly specific. So AEG has a wonderful, above 90% specificity for diagnosing seizures. So if we see a seizure on AEG, it's almost certainly a seizure. On the left side, you can see these are old recordings from an electromed machine when we first started recording AEG on babies, where these things are done using ink and paper, so we had to refill the ink when we ran out in the middle of the night. Nowadays, on the right-hand side, you can see we can actually look at the underlying EEG. So if we're not sure, we can actually look at the raw EEG to confirm it's a seizure or not. So it's incredibly useful to diagnose seizures. Now, there are limitations because although the AEG is incredibly specific for seizures, there are some issues around sensitivity. So it's really a global recording of brain activity. So it's going to miss things which are far away from the electrodes. So we record centrotemporally, so any seizures arising outside of that area are more likely to be missed. It's also susceptible to artifacts, more susceptible than conventional EEG. And although it requires much less training, and it's certainly a point of care test, it still requires training. And it's well documented that actually it's actually poorly reliable in the hands of inexperienced staff interpretation. So there's an example here I've put of an old trace. So when this trace starts, you might look at it and think, oh, this is a discontinuous pattern, it seems okay. In the middle, I've slowed the trace down, which you could do on the old machines. And you can see these big spikes of activity. And then we go pancuronium, and you can see that completely abolishes those spikes and actually reveals the underlying background activity, which is incredibly abnormal in depressed. So this, I think, illustrates, artifacts and the difficulty in interpretation of AEG. So what I would say is AEG is complementary to conventional EEG, and it's certainly not a replacement for it. But I think certainly in the UAE here, there aren't many people who have the gold standard of continuous video EEG for, let's say, 72 hours whilst they cool a baby with HIE. So in the future, there's quite a lot of interest now in looking at long-term outcomes of preterm cerebral hemodynamics, using machine learning and artificial intelligence to be a little bit better at seizure detection. But certainly all of these things are still experimental for the time being. So I'll now shift focus to ultrasound. Ultrasound, safe, it doesn't use ionizing radiation, you don't need to sedate the baby, it's cheap, we can do it at the cot side, we can do it quickly, and we can do it again and again and again. So it's pretty much the dream point of care test that we have. We can use different windows. You're all familiar with the anterior fontanelle, but there are actually other windows we can use for specific indications. For example, the mastoid foramen is particularly good at looking at posterior fossa bleeds. We can use different transducers and frequencies to look at deeper or more superficial structures. And we have standardized views, which makes it very helpful for comparing our images between operators, even between institutions, when we're transferring patients. So this is a list of indications for brain ultrasound. You don't have to read it. This is proposed by the American Institute of Ultrasound and Medicine. So I'll pick out 3 clinical scenarios that it's most useful in. The first is screening preterms. The second is post-hemorrhagic ventricular dilatation. And the third is when we see abnormal neurology. So screening preterms, there's lots of guidelines about when to do it, how often to do it, which babies to do it. I won't go into that. There's kind of like an ideological split between European and North American centres. But when you get down to the basics, there's a first scan, let's say in the first week, which is trying to look at, trying to detect antenatal brain injury, congenital malformations, intraventricular hemorrhage, and cerebellar hemorrhages. And a later scan, let's say between 2 and 6 weeks, which is looking at detecting post-hemorrhagic ventricular dilatation, white matter injury, arterial infarcts, sequelae of brain infection, and those rare late intraventricular hemorrhages. So you're all familiar, this is Volpe's modification of Papil's 1978 classification, looking at the severity of intraventricular hemorrhage. And the beauty of this scoring system and the beauty of cranial ultrasound is that we can do serial scans. So we can monitor very nicely the evolution of injury and understand the maximal extent of the injury, which is vitally important when we think about how this will predict long-term outcome. So this is from one study. This is a national Canadian study of, I think, more than 3,000 babies looking at the severity of their intraventricular hemorrhage. And you can see it actually as quite a strong predictor of neurodevelopmental outcome. So the red bars show at 18 to 24 months of age what percentage of babies had any kind of a neurological impairment. And the grey bar shows those babies who had severe disability at 18 to 24 months. And this data is very consistent with many other studies throughout the world. So we know actually that cranial ultrasound can very reliably predict outcome. So why is this important? So I think there's 3 things. One is there might not be an effective treatment for intraventricular hemorrhage as it's happening, but I think it helps the whole team think about brain protection. So when we see IVH, we're much more interested in blood pressure and CO2 and all those kind of things. The second is, as you can see here, it's a very good predictor of outcome. So this helps us decide which babies we need to do further imaging on, which babies we need to perform neurodevelopmental surveillance on, and which babies we need to intervene early on so that we can reduce their disability later in life. And the third thing, I think, which is underappreciated is that the parents deserve to know this information. We tell them about the PDA and 100 other things, But actually, the big things that parents ask us are, will my baby survive? And how is their brain? Will they have problems later in life? So I think parents deserve to know. So I think there's three big reasons to do these scans. So then let me talk about something that cranial ultrasound is ideally suited to, which is post-hemorrhagic ventricular dilatation. This is the consequence of severe intraventricular hemorrhage. It's associated with really significant morbidity. And cranial ultrasound is absolutely the tool of choice to make the diagnosis and to monitor the condition. So several measurements have been proposed, but actually nothing really supersedes the ventricular index or the ventricular width, first proposed by Malcolm Levine. And you can see his chart, which still people use, proposing a threshold for intervention, which is 4 millimeters above the 97th centile. Now, there are other centile charts, and there are, one thing that's very useful is the Canadian Brain Group have provided a lovely Excel spreadsheet where you can put in values to help you monitor and intervene. But I still think this holds up really nicely. And serial scanning and early diagnosis are incredibly important because we know that early intervention is better. So early, I mean that treating when you see ventricular dilatation on the cranial ultrasound means better long-term outcomes than waiting for clinical signs like increased head circumference. So we need to, in order to intervene earlier, we need to screen and monitor earlier. And there's certainly some evidence, more than some evidence actually, that early drainage is better. So draining when we hit that 4 millimeter threshold, for example, is better than waiting for to far exceed that threshold. So we're reducing disability in this way. The other reason why extensive monitoring, sometimes we need to do it sort of twice a week, is important, is because these babies can follow different paths. So some of them, 40% of them, will stop dilating and not need treatment. Some will rapidly progress within 1 or 2 weeks to need neurosurgical intervention. And some will slowly grow. And even a third of those will eventually need neurosurgical intervention. So the only way we're going to know is by scanning. And the last clinical scenario I want to talk about is the baby with abnormal neurology. So cranial ultrasound, again, might not be very sensitive. So we're going to miss a lot of stuff, but it's very specific. So if we see one of these things, we've got the answer straight away. Okay, and that's going to help everybody in the team, and it's going to help the parents. So here on the left side, a baby with seizures, top and bottom, you can see this large area of echolucency. That's an ischemic infarct. So you have your answer there already. You don't even need to wait for an MRI. The middle panels, at the top, you've got ventricular dilatation, periventricular calcification. This is congenital infection with CMV. Below that, large, prominent subependymal cysts and a vasculopathy. That's congenital toxoplasmosis. Top right is a baby who's floppy, not feeding. This is hollow presencephaly. And in the bottom corner, a baby with focal neurology who's got a large subgaleal hematoma. So in all these situations, you've got your diagnosis at the cot side within minutes, and that clearly is going to improve outcome. So what about the limitations of ultrasound? Well, I've already alluded to the fact that it's very specific, but not always so sensitive. So it's going to miss small lesions. It doesn't have the same tissue resolution as MRI, particularly at the extremities of the brain where the probe can't quite sweep to. It's going to miss subtle disorders like migration disorders, and the view of the posterior fossa is limited. So, for example, on this picture of the MRI on the left, you can see there's a cerebellar hemorrhage there, which might be missed by cranial ultrasound. But again, we come down to expertise, because actually, in the hands of an expert, they might see some brightness there, and that would prompt them to look at the mastoid view and identify this. So again, expertise is important. So the future, again, this is all very experimental, but I think this is a really interesting study that I read. This is the rat brain, where they've used focused ultrasound to look at blood flow in the brain. And you can see that it's a very close correlation to the EEG. So this is a window into cerebral blood flow in real time, and it's highly accurate. So maybe this is the way forward when we're worrying about blood pressure and how to monitoring the functional echo. Actually, maybe this is a better answer, but time will tell. So to conclude, AEG brain ultrasound, they're wonderful point-of-care tests. I would say useful is like a British understatement. They're incredibly useful and valuable tools. They're ideally suited for the NICU because we have patients who are exquisitely vulnerable to brain injury and hard to move. And if we use these tests in the right way, hopefully I've shown you data that shows we can reduce disability. And the picture here just shows that like cranial ultrasound and AEG, point-of-care testing is nothing new. People were testing urine in medieval times to give diagnosis at the bedside. So thank you for listening, and thank you for sticking around.
Thank you very much, Dr. Nicholas. Actually, I want to thank all of you for staying till the end of this day. We will have the last talk of our day today by Dr. Macy regarding diagnosis and management of neonatal seizures.
Great, thank you. So for my next talk, I'm going to discuss the identification and management of neonatal seizures. I still do not have any disclosures. And our learning objectives for the next bit of time are to describe the epidemiology of seizures in critically ill neonates, to review the seizure types that present in neonates and the best practices for diagnosis of seizures, and to finish up by reviewing data regarding the management of seizures, including the role of treatment algorithms. All right. So unfortunately, we know that seizures are very common in the neonatal period. And regardless of whether it's intrinsic injury to the brain from a hypoxic ischemic event or a stroke, or if injury to the brain is secondary to a more systemic issue involving the lungs or the heart, we know that seizure is the most common way that a neonate will present to let us know that they have suffered a brain injury. The incidence of seizures in term neonates is estimated to be about 1 to 5 per 1,000 live births, with higher incidences reported historically in certain populations, including preterm neonates and very low birth weight babies. As more hospital centers are developing neonatal neurocritical care service specialties and have been reporting on the kinds of cases that they're seeing, we know that seizure is the most common question for consult, representing about 25% of consultations, along with HIE, help with management and prognosis. And why is it that seizures are so common in neonates? Well, there seem to be it's multifactorial, but there does seem to be some age-dependent mechanisms that favor excitability in the brain. So particularly in the neonatal period, we know that the neurotransmitters, which are excitatory for our nervous system, glutamate, for example, those neurotransmitters are at extremely high rates of expression in the brain, and actually after the neonatal period trim down to reach the normal expressive rates of an adult brain. And simultaneously during the neonatal period, the neurotransmitters that affect our inhibitory system of the nervous system, the GABA receptors, are at an actual nadir, so at a low point, sort of providing this mismatch of too much excitability with too little inhibition, and just sort of creates the perfect storm for a slight injury to result in the presentation of seizures. As I alluded to in my previous talk, the most common etiologies are acute causes for seizures, and those lead to acute symptomatic seizures. So something happens, and in response to that, the baby's brain begins to have a seizure. Historically, HIE, or hypoxic ischemic encephalopathy, has been the most commonly reported etiology for term neonates. And while HIE can also be present in preterm neonates, the overwhelming literature would support that the most common etiology for preterm neonates remains intraventricular hemorrhage. Those two, along with intracranial infection and ischemic stroke or vascular insult, represent about 75 to 80% of causes of neonatal seizures. Other acute causes to consider are transient metabolic disturbances, so things like hypoglycemia, hypokalemia, hypo or hypernatremia. We see much less frequently. However, they're important to consider and think about and ensure that those aren't the causes, because obviously repletion of the metabolite will treat seizures rather than seizure medication. And as we just spent the last talk discussing, less commonly, but still accounting for up to 15% of cases, are the genetic epilepsies. So depending on the presentation of the patient, genetic epilepsies may rise higher on your differential, pending the patient's history and course. The timing of seizure presentation can also help with diagnosis. So very early after birth, when we're seeing seizures, they're more likely to be due to the transient metabolic disturbances that we discussed. HIE also presents most typically in the first day of life with seizures, within that first 24-hour period, as a median in most studies. As you're getting to days 2 to 3 of life, the other acute symptomatic etiologies, such as vascular insult and infection, are more likely to present around that time point. And as you're getting later into the neonate's course, again, beyond days 2 and 3, that's when we're starting to see the presentation of the genetic epilepsies, the metabolic disruptances, disorders as well. You'll notice that after day 3, there's a little bump where we see HIE again. This is for neonates who undergo therapeutic hypothermia. We know from numerous studies now that most neonates who experience seizures in the context of HIE have seizures in that first 1 to 2 days of life. However, upon rewarming, there's a smaller subset of patients, about 5 to 10% of patients, who may experience seizures newly as they are rewarming. So just something to keep in mind during that transition period there. So how do we diagnose seizures? Well, historically, neonatal seizures sort of were broken into these 3 categories. So there were electrographic seizures, which is a seizure that is visible on EEG monitoring. And an electrographic only seizure would be a seizure where it's only visible on the EEG. There are no outward manifestations that the neonate is demonstrating. So without EEG monitoring, you would not see this seizure. On the other end of the spectrum are clinical spells. So these are stereotyped, repetitive, abnormal movements that the neonate is doing that may not have an EEG correlate to them. And this group has become more controversial with time, and we'll get to that in a second. And sort of the melding of the two of those in the middle there are the electroclinical seizures. So these are seizures in which we have an electrographic seizure on EEG, and at the same time, the patient has an outward clinical manifestation of an activity or behavior or lack of behavior that corresponds with the EEG change, and that's called an electroclinical seizure. Looking more specifically at seizure semiology, I know in the last talk I spent time going through the ILAE's classification, new classification of seizures and how that relates to the genetic epilepsy specifically. But I wanted to step back here for this lecture and talk a bit about the Volpe classification that I think probably more people are familiar with as it has been around for longer. So the Volpe classification of seizure semiology, which again, semiology is just the look of what the baby is doing during the seizure, has 4 major categories. So there's clonic activity, which is a slow rhythmic jerking that's non-suppressible, usually of an extremity or extremities. We can see that the incidence of that is not super high. About 10 to 25% of patients with electroclinical seizures will have a clonic component to their seizure. But when we see the clonic activity and we're monitoring these children with EEG simultaneously, very often, more often than not, there is an electrographic correlate with clonic seizure activity. The next category in the Volpe classification is tonic seizures. So tonic just means an extension, a sustained extension or stiffening of the trunk or an extremity or extremities. And again, it's present when we look across cohorts, reported clinically in about a quarter of patients. However, when we look at EEG monitoring along with that movement in cohorts, it's variable whether or not there is an actual electrographic correlate along with the reported movement. Myoclonic seizures are sort of a large rapid jerk that can happen singularly or in succession of the trunk and extremities. This is a rarer phenomenon for us to see, as we discussed earlier, and when we see it, we're typically thinking of the non-acute causes of seizures more along the genetic pathway. And similar to tonic seizures, the electrographic correlate, when we look at this across cohorts, is variable. Sometimes there's an electrographic correlate, and we can say it's a definitively seizure, and other times there are forms of myoclonus that do not have electrographic correlate and are not actually coming from the cortex of the brain and would not necessarily qualify as seizures. And then the sort of fourth category in the Volpe classification are the subtle seizures, so sort of everything else. So these are going to be the abnormal movements of the eyes, the abnormal movements of the mouth, the infamous bicycling, vital sign changes, autonomic changes, a lack of movement, sort of the wastebasket term for everything that is not what I previously mentioned. And what we can see from looking across cohorts is that subtle movements or these abnormal subtle movements are very common in neonates. However, when we look at how often those movements actually have an electrographic correlate and represent true seizure activity, it's actually very, very rare. And so I think putting all of this together, thinking through the classification, we can feel very confident, rather confident at the bedside that when we see focal clonic activity in a neonate, that is non-suppressible, meaning that if you try to hold that movement down, you still feel the beating of that extremity against your hand, is the most reliable seizure or semiology for neonates. But all of the other semiologies are much more variable, and we have to be a bit more discerning before we kind of decide, is it a seizure or is it not? And let's see if this plays. This is just a video of a neonate here. We see the right hand has this clonic rhythmic jerking, which is subtle, but becomes a bit more pronounced as the video goes on. So this would be an example of a clonic seizure. Again, very reliable. When we see this, it would be great if someone went over and tried to lay their hands on the arm and see if they could stop the movement, and we would be able to see/feel that the movement persists. So when we see this kind of activity, again, that's non-suppressible, we can feel pretty confident that there is, this is actually representative of seizure activity. And the clinical diagnosis of neonatal seizures is difficult. And my colleague before this did a great job of going through some of the difficulties with discerning abnormal movements that are seizure or not seizure in critically ill neonates. And this is just one study that I've always enjoyed that really highlights this point. So this was a study of a group of doctors and nurses from the bedside, variable levels of experience from trainee to attending, from nursing students to senior nursing in the NICU. And they were provided videos of neonates having abnormal movements. Now, the study providers did know which represented electrographic seizures or had an EEG correlate and which didn't. But the bedside people who were given the videos did not. And they just asked them to sort of rate each video to determine if they thought it was seizure, representative of seizure or not. And what you can see is the mean number of correctly identified videos was only 50%, so 10 out of the 20. And that did not vary by whether or not it was a doctor versus nurse assessing it or by the level of experience. Notably, they did have the highest percentage of correct responses was for clonic movements, so that is promising. But probably what's even more concerning is that though it was sort of a flip in a coin to determine whether or not you knew if the movements were seizure or not, the agreement between the providers was abysmal, really poor at 0.21 to 0.29. So even though we were not great at guessing what was or wasn't seizure based on just the movement, we also did not agree with each other at the bedside about what was or wasn't seizure. And obviously, without knowing For sure, if abnormal movements represent seizure, we have the risk of exposing neonates who are already very vulnerable to medication and interventions that they may not necessarily require. And on the other hand, not intervening when it may be appropriate when patients really are experiencing seizures. So when we talk about electrographic seizures or seizures that are present on an EEG, we have a very specific definition that we use that is listed there. It's a sudden abnormal EEG event with a repetitive and evolving pattern that has a minimal peak-to-peak voltage of 2 microvolts and lasts for at least 10 seconds. And here we just have an example on the screen of a seizure coming from the right central region. The onset is roughly where I have the red arrows, and you can see that there is evolution in the frequency of the epileptiform activity as well as the voltage or amplitude of it. And then as it progresses beyond the second half of the page, we see that it also has a spatial evolution and has sort of recruited additional areas of the brain into the seizure. Status epilepticus is defined slightly different in a neonate. It's an electrographically based diagnosis where the sum duration of electrographic seizure activity comprises at least 50% of an arbitrary 1 hour epoch. So roughly 30 minutes within any given hour of EEG activity. Doesn't have to be continuous, but if there's 30 minutes total or more, then that meets the criteria for status epilepticus in a neonate. The problem, though, is also that observed seizures are usually just the tip of the iceberg, right? So when we do rarely have the neonate with electroclinical seizure, so they have a clinical component that matches with an electrographic seizure, that often just represents a small fraction of the true seizure burden that they're having. In up to some 90% of certain cohorts, patients experienced subclinical or EEG only seizures, which again means that there are seizures on the EEG, but the patient has no clinical manifestations of the seizures. Part of this is due to a topic called electroclinical dissociation. This is essentially when you have a patient that actually does have electroclinical seizures and you treat them with anti-seizure medication. The medication calms the clinical manifestation of their seizures, so we all feel great at the bedside. However, if you continue to monitor their brain activity on EEG, we'll see that there is a persistence of subclinical or EEG only seizures. And so that's this dissociation between the clinical seizure and the electrical seizure from medication, but the actual seizure burden continues. So subclinical seizures are very frequent in neonates. And here we just have an example of that. Sorry. So here we have the neonate in the middle of the screen. And if you watch him, you will see that there are no movements or changes in the neonate. But if you look at the EEG that's actually running, this bar shows that the EEG video is playing, we see that there's this rhythmic pattern that will evolve as we're going across the screen. We're starting to see the voltage and the frequency change. More areas of the brain are becoming involved in this pattern. And this is an example of a subclinical seizure, actually subclinical status epilepticus. This pattern continued off and on for hours in this neonate with no outward signs, clinical signs of it. So for these reasons, really, EEG is necessary, in our opinion, for the diagnosis and management of seizures in critically ill neonates. And the two main things are that just clinical seizures are really difficult to diagnose. And then what we just discussed, that many neonatal seizures have no outward manifestation. And without EEG, you really can't know the true burden of seizure that a patient is experiencing. So to that end, the American Clinical Neurophysiology Society had published a guideline in 2011 regarding continuous EEG monitoring in neonates. And you can see they note here that conventional video EEG is the gold standard for seizure detection and quantification and should be used when it's available and able to be used primarily for evaluating for seizures and encephalopathy. And they provided a host of standards and guidelines on how to apply neonatal EEG. And they also provided us with a list of patients for whom there's a high risk for seizure, and for whom, because of that high risk, they recommend a minimum of 24 hours of continuous EEG monitoring to screen for seizures. And you can see listed there, we have categories like acute encephalopathy, which encompasses HIE, neonates with pulmonary and cardiac disease, particularly those who end up going on to ECMO, or neonates with congenital heart disease who undergo repair and require cardiopulmonary bypass for that repair, neonates with established central nervous system infections or traumas that result in intracranial bleed, are known genetic disorders and screening for them, as we spoke about before, vascular changes, prematurity that has associated intracranial hemorrhage, and then high risk neonates who are on a paralytic and therefore obviously wouldn't have any manifestation of a seizure if we were worried about a brain injury. Most recently, I think I've alluded to this paper before, but the International League Against Epilepsy has published the new neonatal seizure classification back in 2022. And they actually took a further step to sort of say that EEG is required to diagnose neonatal seizures, given some of the controversies with clinical diagnosis of neonatal seizures. They have their schematic here that sort of goes through how to approach a patient, or neonate rather, with suspected clinical seizures. And their first step is to connect them to some form of EEG. And if the movement that's of concern does not have an EEG correlate, then it's actually moved out of the seizure category and considered a non-seizure episode. And then to move forward and be considered a seizure, there actually has to be an electrographic correlate. And then from there, seizures are subcategorized into electroclinical, clinical plus EEG melds nicely together, versus electrographic only, where there's just the EEG changes, but the baby looks fine outwardly. And they have included that delineation in their larger sort of schematic of how to evaluate neonates with seizures, and looking at the comorbidities and etiology, assessing for epilepsy syndromes, to sort of package everything rather nicely. But again, seizure type all depends on the electrographic seizure. And just a brief word on amplitude integrated EEG. You guys had a beautiful presentation just now on it, and I know that there's more talks tomorrow related to this. But just to say that continuous conventional video EEG is the gold standard of neonatal neuromonitoring. Obviously, everything that's assessed on continuous conventional can't be assessed on amplitude integrated EEG. And while AEG does a beautiful job of looking at encephalopathy and longer term and short term outcomes, specifically looking at it for seizure detection, as my colleague previously mentioned, has good specificity, but sensitivity is lacking. The numbers I have quoted here just from a recent systematic review looking at the sensitivity and specificity of AEG. And they note that you can increase your sensitivity by using different EEG modalities. So if you just have a single channel AEG, so one electrode on each hemisphere, the sensitivity is about 50%. If you increase that to dual channel AEG, so 2 electrodes on each hemisphere, you can increase the sensitivity to about 60% for seizure detection. If you have the 2-channel AEG, but also allow the providers to display the raw EEG tracing at the bedside, you can increase your sensitivity to greater than 80%. So all AEG is not equivalent, and that should be taken into consideration when using it. But obviously, continuous conventional AEG is very resource intensive and not feasible everywhere. And I think when it is not feasible, there's certainly a role for AEG, as it very clearly has improved seizure detection over clinical observation alone. And it's just important to recognize and understand its limitations. All right, moving on to management. So just a couple of principles I think I wanted to touch upon for management of neonatal seizures. So the first is to treat early. So we know that a single seizure is very rare in a neonate. And this first table here is data from a multi-center study out of Europe using continuous EEG to screen all high-risk neonates based on that previous table that I provided you guys from the American Clinical Neurophysiology Society. They found that roughly a third of the cohort that they screened had seizures, and you can see there were a mixture of etiologies for their seizures there. But importantly, what I tried to highlight in the table here was that the median number of seizures that they found in their patients across the board was 24. And the seizure burden, so the number of minutes that the patient spent seizing or having seizures, the median total was greater than an hour, so 68.5 minutes. So again, I think this just highlights that once a neonate starts seizing, it's very likely that they're going to continue to have seizures without an intervention. And this matters because we're getting more data, but studies are now showing that an increasing seizure burden is in fact associated with worsened outcomes. So I just wanted to highlight one study that kind of drove that point home for me. This was a study with about 50 term neonates with HIE, and they went back and looked at their seizure burden, all electrographic seizure markings, and then their longer term outcomes. And they defined an abnormal outcome as having an abnormal developmental testing score at age 2 to 4 years, or having received a diagnosis of cerebral palsy or epilepsy in that same time frame. And if you look at the smaller table, I'm not sure how well it's projecting, but on the bottom right-hand side here, we see that there was significant difference in the total seizure burden and the maximum seizure burden between neonates who ultimately had a normal outcome versus those with an abnormal outcome. Those with a normal outcome had a median of 25 minutes of seizure burden versus those with an abnormal outcome had a median of almost 200 minutes of seizure burden. And when they did some more advanced sort of statistical analysis, they found that for a total seizure burden of greater than 40 minutes, the risk of an abnormal outcome increased essentially tenfold. So again, seizure time is brain, and it really does translate into worsened outcomes. So just keeping that in mind and trying to treat early matters. And we now have evidence that treating early actually can impact the effect of your treatment. So this is a recent study of 69 infants who were treated with anti-seizure medications after electrographic seizure onset on continuous EEG monitoring. And they categorized the patients into 3 subgroups: those who were treated with medication within 1 hour of seizure onset, those who were treated with medication between 1 and 2 hours after seizure onset, and those who were treated with medication more than 2 hours after seizure onset. And what you can see is that the group that had treatment within 1 hour of seizure onset ultimately had a lower seizure burden and a smaller number of seizures. So suggesting that the faster that you get medication into these neonates, the more likely the medication is to be efficacious and to prevent further seizures and decrease that seizure burden, which again, we know can lead to worsened long-term outcomes if the seizure burden is too high. So the International League Against Epilepsy, as I mentioned, I think in my previous lecture, is developing a neonatal seizure treatment guideline, which again is available on their website for review, though has not been formally published yet. But their 5th recommendation there sort of highlights what we just discussed, that treating neonatal seizures, including electrographic only seizures, to achieve a lower seizure burden may be associated with improving outcomes. And so that is a recommendation on their behalf. We also have, I think having a plan is important once you've established that the neonate has seizures occurring. And this is data from a quality improvement study that sort of had their treatment of neonatal seizures, implemented a standardized regimen where they had the specific medications and doses in order, highlighted and available at the bedside, so that when a neonate had seizures identified, treatment could ensue immediately, and then sort of compared their pre and post outcomes. And what they found was that having a standardized treatment plan led to decreased anti-seizure medication with lower concentrations of anti-seizure medication after the plan was implemented, decreased number of neonates who would progress into status epilepticus, and shortened hospital stays after they implemented their plan. And for that reason, the International League Against Epilepsy in their upcoming guideline has also stated that a standardized plan for treatment should be available for management of neonatal seizures in each neonatal unit. So what do you treat with? Well, there have been 2 studies that have looked at first-line treatment for neonatal seizures. The first is the Painter study that came out in, I believe, 1999, and that looked at first-line phenobarbital versus phenytoin for treatment of neonatal seizures. Roughly 60 neonates were randomized to receive either medication, and what you can see is that those who received phenobarbital had a response rate of about 43%. Those who received phenytoin, response rate was about 45%, and when they didn't respond, they received the opposite medication, medication. So the phenobarbital, initially neonates then received, non-responders received phenytoin, and that increased the response rate to 57%. And the opposite happened on the phenytoin side. The non-responders received phenobarbital, that increased the response rate to 62%. So what this tells me is that phenobarbital and phenytoin were roughly equivalent in their efficacy. However, they were incompletely effective. And that's really the data that we've had to go by for many years. And as a result of this study, phenobarbital has been sort of the gold standard for treatment for many years. More recently, there was data, studies that suggested that levetiracetam could be very safe and efficacious as well. So the NEOLEV-2 trial was recently completed, or the last few years, that looked at IV levetiracetam versus IV phenobarbital as first line for neonatal seizures. Their primary outcome was looking at seizure cessation at 24 hours of life. Again, these babies were all on continuous EEG monitoring. And what you can see is that phenobarbital outperforms levetiracetam. The response rate for phenobarbital was 80%. The response rate for levetiracetam was 28%. And that trend continued for their secondary outcomes, which looked at a later time point as well as an earlier time point. Not surprisingly, the adverse event profile varied by the medicines. Levetiracetam, with just one patient having an adverse event with hypotension. Phenobarbital had a higher rate of adverse events with hypotension and respiratory illnesses or respiratory suppression. But the takeaway point, I think, from this study was that phenobarbital is more efficacious for neonatal seizures. And there are ongoing studies, I think, looking at higher rates of levetiracetam compared to phenobarbital. But for the time being, this leaves us with phenobarbital as the gold standard of treatment for first-line therapy. And as such, ILAE has sort of put this as their first-line recommendation. Phenobarbital should be the first line. If there's high consideration for genetic epilepsy, one can consider a channelopathy specifically. One can consider a sodium channel blocker, but across the board, it's pretty much phenobarbital for first line. In terms of second-line medication administration, ILAE recommends that phenytoin, levetiracetam, or benzodiazepines can all be considered for second-line medications for most etiologies. Again, if a genetic epilepsy, specifically those channelopathies, are high on your differential, then considering a sodium channel blocker like carbamazepine, phenytoin, oxcarbazepine can be considered. And also, several groups, including ours, have done work looking at neonates with congenital heart disease and have found that levetiracetam can be acceptable for use in them. So that has been recommended as second line for those patients specifically. And I think just my last point when we're considering treatment is when you start treatment, when you start it, you should also be thinking about what's your end point and what's the duration. Again, the majority of neonates we meet with seizures have acute symptomatic seizures, and their seizures will only be present in the neonatal period. There has been a lot of work, including out of the neonatal seizure registry, that has shown that early discontinuation of anti-seizure medications, meaning before the patient leaves the hospital for those acute symptomatic etiologies, is okay and safe and does not lead to later epilepsy, infantile spasms, or developmental delays. So we would advocate for stopping medication for those with acute symptomatic seizures while they're in the NICU. And that is a recommendation formally from the ILAE now as well. All right, so in conclusion, we know that neonatal seizures are common, most often the results of an acute etiology. The clinical diagnosis of neonatal seizures is difficult, and continuous video EEG monitoring is necessary to accurately diagnose and quantify seizures. Amplitude integrated EEG is a commonly used modality, less accurate than continuous EEG, conventional EEG, but obviously better than clinical observation alone. The presence of seizures, especially with increasing seizure burden, is associated with worsening outcomes. And though treatment for neonatal seizures is imperfect, phenobarbital remains our first-line primary medication of choice. But remember to treat early, as these seizures aren't likely to stop on their own, and there's a better chance of success the earlier you treat. And always be thinking about your exit strategy with medications when you start it for those acute symptomatic seizures. Thank you.
Thank you, Missy. Now the time for the question and answer. Sorry for the delay. Dr. Hogg, if you don't mind. Okay, we're gonna give only 10 minutes, only 2 questions, if that's okay.
Thank you again. I cannot resist myself. It's so, interesting and this thing that we have to ask some question. And thank you from Philadelphia. It's in the maybe early morning there. I have a question for both of you. We talk about the point of care testing. How you put the monitoring, which we called it NIRS, near infrared spectroscopy. So Siobhan, you are using near infrared spectroscopy in your unit, or what you are talking? So any one of you can talk about it.
I can just quickly take that. I know that in our cardiac ICU, that NIRS is used relatively regularly there and primarily monitored by the bedside cardiac intensivist. We in the neurology side have not really been involved with evaluation of NIRS. I'm not sure in our NICU how frequently NIRS is used, and that might vary by indication, but I know for our patients with cardiac, congenital cardiac diagnoses that they are using it.
Yeah, it's a good question, actually. So in Canada, we don't use NIRS. At Imperial in London, we don't use NIRS. I don't know of any neonatal unit in the UK that uses NIRS routinely, just experimentally. I think one of the issues is there's no validated reference ranges because it's different between each piece of equipment. So until we have validated reference ranges that can be repeated between institutions, it's limited in its use in the neonatal intensive care unit. But like Siobhan, there's plenty of units in the UK that use it in PICU, post-cardiac surgery.
I have a question for Dr. Messi. Thank you for that very nice overview of neonatal seizures and providing us evidence-based guidelines. Have you come across cases in which you have used higher doses of levetiracetam, more than 40 milligram per kilogram, and can you then compare that with outcomes with phenobarbital?
Yeah, I mean, I think that that's one of the takeaways from the NEOLEV-2 study was that the 40 milligram per kilogram dose is probably too low, but I think they probably wanted to start lower for safety purposes. For our neonatal pathway, we actually use a dose of 50 milligrams per kilogram and maybe increasing that to 60 milligrams per kilogram to match our PICU status epilepticus profile pathway as well. I think it's hard to say. We know that it's safe to do the higher dosing. And again, in case series, it's been reported to be efficacious at these higher doses. I think until we have the data from the randomized trial, it's going to be impossible to say how much of the difference that, additional 10 to 20 milligrams per kilogram of the dosing does compared to phenobarbital. One thing from the NEOLEV-2 that I thought was really interesting is the effect rate of phenobarbital. I think that surprised everyone because from the Painter studies, the response rate to phenobarbital was so low in the 40 to 50% range, whereas with NEOLEV-2, it was 80% response to phenobarbital. But with this study, I mean, people were at the bedside. The minute a seizure was seen, they were pulling up the medication and administering it. So I think it probably speaks to the time to treatment. And the faster we can get phenobarbital in, it actually probably can be pretty effective and result in us not having to use as much and maybe not get the side effects that we typically think about with phenobarbital. So we're still sticking with that for now, I think, until we have definitive evidence, just because the difference between the phenobarbital and the levetiracetam group, again, with both of them getting very quick treatment, was just so striking.
So I think the point that you have two outcomes here. One is a seizure outcome, whether the seizure stops or not. But I think we have always been concerned, and concerns have been raised regarding the neurodevelopmental outcomes with phenobarbital. So I think we still need to think about this aspect of treating seizures. That was just a comment, but you mentioned in one of your slides, ganaxolone has been approved for CDKL5 related seizures. Have you had any experience using ganaxolone kids with neonatal seizures. And you mentioned that it is in phase 3 trials. Is it phase 3 trials for neonates or older children?
No, this is for older children. So having the diagnosis early will set them up to, be available for the treatment, but it's certainly not something that we're testing at our NICU. This is for older children. And just, sorry, if I could just, another comment to the phenobarbital, 100% agree about some of the concerning data about phenobarbital exposure that has, it's been presented. I guess it's a bit controversial and some others have refuted it. But that's also part of why we recommend early discontinuation and not having these patients on the medication beyond the acute period of, the first 5 to 7 days of treatment for acute symptomatic seizures anyway.
No more question? I think finally, I will ask Dr. Ayman to close the one.
Thank you all. Thank you for speakers. Thank you for everybody to tough it out and stay until the end. It's really nice. You get extra 2 hours of CME for this. This concludes today's session, and tomorrow we'll have exciting program, inshallah. We will start at 9 o'clock. We have 3 sessions tomorrow. It's going to be starting with infectious disease, and then we're going to follow up with procedures, and we're going to have a second round of neurology sessions. So thank you very much for staying with us today, and enjoy your nights, and we'll see you tomorrow morning, inshallah. Thank you.
Just an additional announcement for our moderators and speakers. The gala dinner will be tonight. Pickup time will be at 7:30 p.m. at the ground floor outside the hotel, and we'll be leaving the hotel at 7:45. Thank you and good night.